Good morning, everyone. Can everyone hear me? All right. I would like to welcome my panelists here. Really looking forward to this conversation. To my right, Dr. Freddy Abnousi, Vice President of Health Technology at Meta. And to his right, Dr. Lucica Ditiu, Executive Director of Stop TB Partnership. I think this is a very interesting time in public health right now, and we're hearing a lot about the challenges, particularly this week, I think, with reductions in budgets and resources and the impact that that's having on a lot of health outcomes. I think there's also a silver lining to that. As you know, Lucica, you were saying earlier that there might be opportunities here, and I think one of the opportunities is represented by technology and the role that technology can play in perhaps addressing some of those challenges and increasing access and bridging some of those gaps that we're seeing. So Lucica, I wonder if you can start with, as we're seeing reductions in funding, what is the direct impact that that is having on programs for TB and programs that stop TB overseas around the world?
So thank you very much. And I'm very happy you guys stay here and want to listen a little bit about TB. Tuberculosis is a disease that puts all of us at risk as long as we breathe. So you can eat very healthy, run, put bed nets, have protected sex. You can still get TB, and you can still get it anywhere. So it's a topic of big interest for all of us. So I think there is, as we know, and I don't think there will be a turn back to the era in which there was a lot of generosity in terms of ODA and a lot of money flowing from donors to the countries for different programs. TB was never excellently funding or generously funding, but there was a lot of external funding going to countries, and there still is. But there is a more attention towards what is being funded and how. And there is a big attention now towards more providing services and drugs and diagnostics and a bit less on the fluff part, as it used to be called. So what we see in countries is actually what I think is good that is happening, is a very tough wake-up call, is a cold shower from an over-dependency on donors and looking at finding domestic resources or other investors, but also looking at delivering services in a better way. And that is integrated, that's using technology, that's using AI, that's smartly, you know, the time in which you invest just in a diagnosis tool that is just doing tuberculosis past. So more and more what we see now is an ambition in countries, but also an ambition to do more in an integrated manner, as I said. So for example, we have a miniaturized X-ray, and you can go with it wherever, and then you can look and find, you can see the lungs, you can see the heart, you can see the spine, and you have AI reading that. That makes access to the diagnosis much quicker, but not just for TB. So to sum up, what we see, there is an impact, but it triggers a wake-up call in countries to do things in a different way. And I think that should be available for all of us.
Are you seeing the biggest impact in diagnosis, in fewer people getting diagnosed because they don't have access, or the machines, equipment, or access to treatments? Because we know TB is a condition that can be treated if it's detected early and pretty well managed. So where do you see the biggest hit or the biggest impact?
Well, the sad part is that there were several countries that allowed themselves to have their treatments and diagnostics fully funded by donors. But on top of that, their health system, the workers, the nurses, were also paid by donors' money. So when the US funding changed completely in Q1 of this year, let's put it this way, there were interruptions in the supply chains of this. But there were also thousands of healthcare workers with salaries paid with donor money, i.e. US, but others as well, who suddenly disappeared from the picture. So suddenly there were also a lot of community and civil society people that were accompanying people with TB that come from more vulnerable communities that also disappeared or stopped having salaries overnight. So The biggest, I think, impact is on people being diagnosed and treated. On people being diagnosed. Once people are diagnosed, I think most of countries are really making the huge efforts to get them treated. But to have them found, let's say, ensuring access to them to a proper diagnosis tool is where the struggle is the biggest. Is not necessarily the availability of the tool, that it is big there as well, but is also the accompanying soft part, if I can use that, of people making sure that they have access to it.
Now, one of the consequences of having reduced resources for controlling a condition like TB is that you will see outbreaks, right? More people infected because these pathogens don't respect borders and the ease of travel, which means anywhere, any place, even places where we really don't see TB very much, like the United States, could also be vulnerable to outbreaks. So Freddy, a lot of you might be wondering, what is someone from Meta doing sitting on a panel about global health? But as Lucica said, there's also opportunity here, right? When resources are reduced and there's almost you have to confront kind of redesigning and rethinking the way you manage a lot of things in TB for sure. But tell us about how technology, what role technology, and in particular AI, can play in really addressing some of the weaknesses in the previous system, and that are being revealed now that we have a lot of reductions in the funding that's available for those programs.
Yeah, it's a great question. It sort of takes me back to training a little bit. I remember when I first started training, and the most senior clinicians in the hospital, I'm an interventional cardiologist, the most senior clinicians in the hospital had these immaculate ways of detecting things from a physical exam, listening to the heart, and just picking out the most minute changes in what the valve sounded like, et cetera. And then teaching that to fellows in training, residents in training, medical students. Fast forward a few years, we had an ultrasound that you put on the chest, and we got much more data on what is going on with the valves and the heart and the function. And often I find in a lot of sort of incremental and all of a sudden changes, what happens is you take the existing technology and try to make it better, a better stethoscope, a faster car, a smaller x-ray. And then finally you switch over to just a new technology that does it originally what was intended for, plus a bunch more that improves outcomes in a dramatic way. And I think we're at that shift where we're not trying to learn exactly what the S1 and S2 sounds are supposed to click and move in certain directions, but we're transitioning to a different type of technology that empowers in a very different way. More specifically, if you think about what we do as clinicians, we spend a lot of our time trying to understand what's going on in the patient's life. In fact, anybody who walks in the clinic or in a hospital, out of a 30-minute visit, let's say it's a 30-minute visit, the first 25 minutes are, tell me about your life, what are you doing during the day? Tell me about does this make your symptoms better or worse? And we've got all these code words, et cetera, that we're trying to understand. And often if a complaint or a symptom comes in through the computer, the first thing you want to do is bring the patient in and want to talk to them. The reason we talk to people, which is a critical part of what we do in diagnostics, is to understand what's going on with them. But that part is really hard to scale. And that's why people often think that though most of health happens outside of the hospital and clinic, it's those intervening infrequent events of coming to clinic, coming to the hospital that matter.
And of course, not everyone goes to the hospital.
Yeah, or has access to it.
Or has access.
Yeah,
right.
So in that context, the question is, are we starting to broach towards an area where the understanding of the human being, the empathy that's generated by that, being able to walk in a person's shoes, is finally going to happen? I would argue, if you just zoom out from where we are today to the next 5 or 10 years, we're going to be in a position where contextual AI, which is the physical world, not the digital, the physical world, through videos and cameras that we have on wearables, will be the leading source of empathy and understanding, so that you may be able to actually scale all those things that are happening in hospitals and clinics. The reason why 100 years ago, people used to go to the house to visit someone who wasn't feeling well. Today, why people go to urgent care and so forth. You may be able to scale those things to dramatically change, not a better stethoscope, but just moving straight to ultrasound. And I think that's where we are today. The glasses I'm wearing today is a step towards that.
And we were just backstage, and Lucica, you got very excited when you were talking about these glasses, and I want you to like recreate that conversation we had, because I think it really illustrates really the power and potential of this, particularly in TB, in ways that we can kind of expand and bring care and awareness to more people, right, with devices like this.
Yeah, absolutely. So, it's great what Concordia does bring us together, so it can be some great partnership. So what I got excited, beyond the fact that it's really cool, is the fact I went in a this, you brought the angle of empathy and, understanding people, which is so important. I was looking more on the diagnostic part, right? Because with these glasses, you can detect cough, breath, you see. We often, I'm a clinician as well, a pulmonologist, so you have cardiac and pulmons here.
Partners.
And partners. Very often people don't even realize, you see TB, by the way, 40% of people with TB are asymptomatic. Can you imagine? They don't have a big cough. They have this. And very often, very, very often, we have patients in front of us or people coming for something, but you ask, do you cough? How much you cough? I don't. And in front of you, he coughed 3-4 times. So imagine, or the breath is changed. And there are also AI applications that analyze the type of cough and direct to what is a more predictable diagnosis to have. So this can be tremendous. Cardiacs as well have symptoms that are very much associated with the breath, with the sweat, with slowing down, with how you move. I mean, in a way, sky is the limit. Beyond the understanding the environment in which the person works and lives, which is an area that requests so much attention, the diagnosis part of it is extremely important. So I really hope that we will look together or partner at least to try and understand how this can be very useful in some of the, in some of the areas and some of the countries where we need this kind of help. Because reality is very difficult to have access to a doctor or to a diagnosis in very many countries in the world. So the more we can do to bring diagnosis close to them, or the understanding of the persons using all these tools, that's the future.
Yeah, and if I could add to that, I think, when you see somebody, the 25 minutes of conversation you have, to me, is a diagnostic.
Yeah.
And so I think that, like, if I was to sort of map out a framework of how this looks in the next decade, it looks to me this way. There's sort of 4 agents or work streams or helpers or empowering tools that I think are interesting. One is what we think about as like the collection or the archivist. The second is a diagnostician or the risk stratifier. The third is the planner, and then the fourth is sort of the coach, if you will, or the, let's call it coach or health empowerment tool. And the archivist should be able to understand what's going on with you, where health really happens, which is outside. Certainly it needs to be grounded in labs and other diagnostics that we certainly get, but they're not throughout the day most days. And then it needs to inform, with the diagnostician in the middle, what are your odds of success or risk stratification, and odds of success against your goals. Let's say part of your goals are to become really fit or hit certain goals or to be able to get to some of the sort of preventive health measures we're going for. And then together those two work with the planner to instigate, things are going fine, or your risks are at certain level, you should probably go and see someone. And then the fourth is the engagement of that. And I think for consumers or people in the planet, you really should only interact with the fourth. But the first 3 are plausible in that framework. I would say the biggest gap in those is being able to take the diagnostics that currently exist, bring them together with what I think is the largest missing data set, which is the empathy part, because I think that's a diagnostic on its own. And I think if you have that, you perhaps don't need me, and you perhaps don't need your services, right? Sure. And I think the risk stratification and direction of funding towards solving, where as a scalpel rather than a hammer is possible in that case.
And if I can say something, because I actually love so much to bring empathy into this discussion. You see, I don't know how many of you are from I'm Romanian, so I did my medical preparations in Romania, but then working within UN and with WHO for a long time and then out, we don't pay attention too much in the medical school about understanding the human in front of us. And very often, the time we spend with the human is so limited that you don't really understand the environment. And very often, what happens around an individual is essential for the diagnosis. So that's very important, what you just said. I just wanted to emphasize that.
And also, like, some of the things we ask people to do are completely unreasonable.
Yes.
Right? I think, go take these medicines 3 times a day.
Yeah.
At
And
these
good
times.
luck.
I mean, I will tell you, to share too much of a personal story, my wife is also an interventional cardiologist, and she happens to need to take thyroid medicines. With our first kid, she's a physician. She knows all the risks of not taking thyroid medicines while you're pregnant, et cetera. So she's got all the incentives lined up, right? She doesn't need reminders, all that stuff. She still missed it.
Yes.
And felt terrible about it. But this concept of being able to be compliant with medicines without any help, and then we call it as physicians medication non-compliance.
Yes.
It's bullshit, excuse my French. It's just it's just an ask that is a false ask.
And in TB, sorry, but
it's even harder, right?
And in TB is even worse because once you interrupt the treatment, you create resistance. And to have a resistant bug of TB floating around, it's already there, and it's a lot in Eastern Europe, for example, and in other parts of the world. But that's because you forgot to take a dose of treatment. And very often you don't understand why. And then you put a lot of systems to check the person rather than understanding why he or she missed the treatment, why she or he decided, or what happened. So that's actually awesome.
And historically in TB, right, there's been directly observed therapy where you took community workers, people in the community, more people, right, and investment in resources to actually watch people take their medications to ensure that they take it to avoid that resistance. So these are all areas that it seems that technology can really play a role in helping to address some of those challenges. And also, I think what's interesting is we're seeing now a shift in the medical care community to putting a lot more responsibility, may be one way to look at it, but also power, right, in the hands of patients where they're the ones generating the information, the symptoms, and instead of limiting that interaction to 15 minutes with the healthcare worker, if they can get access to one, they're generating this data, which can be extremely helpful in being an initial triage, right? How close is Meta to kind of collecting that data? What is Meta doing to, whether it's in TB or cardiology, to really turn like that empathetic, version of AI into something that could be realistic in, let's say, 5 years, 10 years?
Yeah, so we don't necessarily work on TB solutions, et cetera, but what we do work on are the platform technologies, such as these glasses that I'm wearing today, the contextual AI that goes into that. And our hope is that the world does well with it.
And partnering with, physicians and groups like
well, we're not
Stop
quite
TB.
there yet, but we're at the beginning of this journey, and the discussions we have today really are focused on what the next 5 or 10 years look like. But there's going to be 1,000 use cases I haven't thought of today that certainly people are going to be able to build for over time, and we are super excited to try and decrease inequities in health outcomes, which are often driven by zip code in most senses than anything else. And in that context, we're building towards a democratized version of this. I think if you build tools that are thousands and thousands of thousands of dollars, for example, it's really hard to get that to scale. But most people across the country now have smartphones, and I think that is a really good indication of if you build it, produce really good value from it, there's going to be technologies that built on top of it. And we're trying to get in on the ground of making the base technologies that everyone can scale to. So I feel like I'm selling knives here, but these are relatively well priced. And over time, my hope is that all these technologies become easier to reach for most people.
Lucica, in our last few minutes, I wondered if you can just address, given where we are today with funding crises, and you said that you still see this as an opportunity. Are you overall optimistic or more concerned about our ability to continue to manage and control TB and give people who need it the services that they need?
You know, I'm very ambitious and I never give up. So I'm a cockroach. So I survive in any conditions, and Stop TB survived also over many dramas, including this one. You know, we went with this empathy angle towards, you know, it's all in our will, you see. I find it ridiculous that tuberculosis, which is a disease of thousands of years, our grandparents here, there, suffered of TB. I think they will twist in the bed, realizing that we are still struggling with it. You know, Robert Koch, who first saw Mycobacterium tuberculosis, did it on a microscope. 40% of people with TB are still diagnosed with microscopy these days, you know? He will be shocked to see your glasses, right? And the car and the planes, but he will be very comfortable in a TB dispensary because there is a lab with a microscope diagnosing TB. So it's in our will. So there are countries, you know, just to say one thing, Nigeria had was at 30% case detection rate, meaning from people estimated with TB, how many they found. In few years, they went to 78%. It was very much a drive to show that it's possible. And there are few countries that are trying to own the response and also do much more. So it's in the, if we want to do it, it's possible. You know, you can be very smart. There is nothing in this world that can stop us as human beings to achieve if we want to do it. What it matters is, do we care for the people with different zip codes enough? Because TB, even though it's a risk for all of us, let's be very clear on that, it's more in some parts with a different zip code. Do we care enough to deal with and to support the people there to be able to end it or not? That's actually the real question, yeah.
And Freddy, let's just end with you. And how responsive has the medical community been to adopting, as you said, you know, you've got the platform, you're sort of handing it to them on a silver platter. How responsive has the medical community been to seeing the potential of something like the glasses or, you know, AI in streamlining a lot of what they do?
You know, I was quite pessimistic about this when we started. I had a pager not that long ago. And faxing is still happening.
There might be some people who don't even know what that is.
So, and in that context, as you know, healthcare has been very slow to adopt technologies. I got to say, I'm blown away how quickly the adoption of AI is occurring in the healthcare system today. The part I'm excited about was the adoption. The part I'm disappointed in is the majority of health AI or healthcare AI that's occurring today is to really extract more rents from the existing system. How do we, you know, codify the visit better? How do we code better, and so forth? Which is, you know, I think it's good, but it's a better stethoscope. It's a faster car. It doesn't go to address some of those inequities, but I'm really optimistic that people are actually adopting it. As part of that, I think we've got to start thinking about how to not just run healthcare more efficiently, which certainly is a need, but how do we improve health outcomes through empowerment, particularly as we look at doctor shortages over the next couple decades and so forth. So I'm optimistic.
Okay, great. Good note to end on. Lucica and Freddy, thank you very much for your insights. That was very interesting. Appreciate it.
Thank you.